Morning. I'm Lisa Pascual, and I'm the Chief of PM&R in the Department of Orthopedic Surgery here at UCSF and the Chief of Rehabilitation at Zuckerberg San Francisco General. I'm sorry that I can't be with you here this morning, but thanks for attending the conference. It's very much appreciated. I have no relevant disclosures. The goals for my brief talk today is to highlight that patient recovery after orthopedic trauma requires a robust rehabilitation program. But the rehab program doesn't exist in a vacuum. It is really but one component of a system of interdisciplinary care. I'd also like to highlight how rehabilitation fits into the American College of Surgeon guidelines and underscore the impact of biopsychosocial factors on functional outcomes and recovery, and for us to become familiar with what might comprise the best program or model of care, looking at the trauma collaborative care model and the AOS practice guidelines. Most of us who practice at trauma centers are likely very familiar with the accreditation process for trauma centers through the American College of Surgeons. The ACS guidelines really lay out multiple requirements for many subspecialties that include orthopedic surgery, neurosurgery, radiology, emergency medicine, and a host of other subspecialties within the hospital. The ACS guidelines also have requirements related to rehabilitation. One of them is that programs are required to have protocols that quickly identify patients who need rehabilitation. Once patients are identified as needing rehabilitation, the team has to perform early interdisciplinary assessments to determine what exactly those rehabilitation needs are and to document what these needs may be. And the ACS also requires that the programs ensure timely delivery of rehabilitation services once they are identified, from PT, occupational therapy, speech therapy, and, if available, physical medicine and rehabilitation. In addition, the ACS requires that there has to be a process by which the team begins to identify the next rehabilitation level of care, and this should be done early on in the patient's hospital course. These transitions of care are seemingly straightforward. Once the appropriate level of care often is determined while you're rounding on the ward, the placement is identified, secured, and the patient is discharged, then it would really seem that our job in getting the patient to the next level of rehabilitation care to promote recovery is done. However, while all of our programs have these rehabilitation systems in place, there is much more to optimizing the functional recovery of an individual, both mental and physical, in the orthopedic trauma population. And the ACS recognizes they recognize this. They acknowledge that poor functional outcomes are related to unmanaged symptoms of pain, anxiety, depression, poor social support, and low self-efficacy. Further, clinical trials suggest that when patient care-centered strategies are utilized to address these psychosocial concerns, this may actually reduce post-injury inpatient readmission rates and ED use. Thus, the ACS recommends that patient care strategies also include peer-to-peer mentoring, development of a trauma survivors program or trauma survivors network, and continuous case management. So let's look specifically at the trauma survivors network. The ACS advocates development of a trauma survivors network to provide peer support, self-management, information and resources, and provider training. However, early efforts of implementing a trauma survivors network program found low utilization of services by both the centers and the patients. As a result, in 2018, an enhanced trauma survivors network program was proposed through METRIC, the Major Extremity Trauma Rehabilitation Consortium, which is a research group that I think many of the faculty here have been involved with. They proposed that an enhanced program of the Trauma Survivors Network be developed, and they termed this the trauma collaborative care intervention, which really utilizes collaborative care and chronic care models to help develop proactive teams to engage and educate patients in self-management. So what is the TCC? It consists of a program that starts on admission and extends over the next 6 months. It focuses on recovery assessment and coaching to help clients set personal goals. that include self-management to overcome challenges of depression, substance use, pain, and to help identify sources of social support. There were 12 level 1 trauma centers that were involved in this project with an intervention group of 397 patients. And measurements and assessment included those for pain, depression, post-traumatic stress disorder, and self-efficacy for return to work and managing financial challenges of injury. They found that there was a small but consistent effect in favor of the intervention group, where PTSD decreased by 12%, depression decreased by 23%, and pain decreased by 18%. However, while benefits were derived from this approach, there was great heterogeneity in its implementation at the various sites. Several approaches are in development to determine what the best model might be, and this might include a patient-driven approach, where patients are provided with a suite of services which they utilize according to their needs and preferences. The challenges, of course, to this approach is how do patients know what their risks and needs are? Sometimes it's not so obvious to them. Then there's the clinician-driven approach, where early assessment to develop prescriptive recommendations of more intensive interventions are assessed by the team. The challenges of this approach is access to any programs that might be needed to address these factors may not be available to the patient depending on what their insurance is. So they may not have access to a comprehensive pain management program or mental health services. So really, the best implementation approach to this trauma collaborative care model has yet to be determined. So I'm switching gears a little bit to take a look at another means that is being utilized to improve functional and rehabilitation outcomes for the orthopedic patient following traumatic injury that is specific to a certain population with an increasingly common traumatic injury, and that is hip fractures. There's been quite a lot of work being done with respect to the development of orthogeriatric services, particularly related to the post-hip fracture population. And that's because by 2050, the incidence of hip fractures is expected to increase by 310% for men and 240% for women because of the aging population and increased fracture-related risk, as well as the prevalence of osteoporosis and increased risk of falling. Hip fractures contribute to the most morbidity, mortality, economic costs associated with fragility fractures. In 2021, Hagee performed a systematic review and meta-analysis looking at various models of orthogeriatric fracture care. Hagee sought to determine what might be the best model of care to employ in this patient population. Would it be an ortho-led service with consultation of a geriatrician, or a geriatrician-led service with consultation of ortho, or an integrated model where both ortho and the geriatrician have shared responsibilities? They looked at the literature in terms of the following outcome: length of stay, time to surgery, in-hospital mortality, 30-day readmission rate, functional outcomes, complication rate, and total cost. They ended up looking at 34 studies, having weeded out the literature, looking for studies that include both qualitative and quantitative analysis. The results revealed in general that utilization of any of these integrated or consult models reduced length of stay by 1.55 days, lowered the risk of in-hospital and one-year mortality, and reduced delirium. Unfortunately, utilization of these models did not change time to surgery collectively, or the meta-analysis was unable to comment regarding any significant impact on functional outcome, complication rates, and costs. And this was felt in large part due to substantial heterogeneity between program types and no direct comparison between the groups. When they looked specifically at the subgroups, they found that the geriatric consult model had a consistent effect on length of stay and time to surgery, and that the shared model with the geriatrician and orthopedic surgeons having shared responsibility impacted in-hospital mortality by reducing it. There really were no consistent findings with respect to 30-day readmission rate or functional outcome. And the conclusion was, as many conclusions are, is that adequately powered RCTs with direct comparison between different models of care are needed. Finally, I just wanted to touch quickly on the AAOS guidelines that were developed to try to identify what factors impacted functional recovery and outcomes in patients after orthopedic trauma. The AOS practice guidelines were developed really looking through the lens of the biopsychosocial model that was developed by Engels in the late 1970s, where he recognized that illness and health are the result between the interaction of biological, psychological, and social factors. In this case, the guidelines focused on the biopsychosocial domains as impacting the recovery process and also the long-term outcomes. They found that the factors associated with patient outcomes included anxiety, PTSD, depression, premorbid psychiatric conditions, smoking, lower educational level, less social support, and resilience issues. The strength of the recommendation to really look into these factors was moderate. Thus, the AAOS recommends that clinicians evaluate for the presence of these factors as they are associated with increased biopsychosocial limitations after adult orthopedic trauma. So, really, what are the next steps? The AAOS concluded that there's a lot of work yet to be done, as we do not know the best way to assess for the presence of these factors. Is it through questionnaires or nonverbal signs, formal interviews? And further, once these factors are identified, what's the best way to intervene? And how often should they be assessed? And how would outcomes be measured? And what are the benefits and harms of intervening? So, really, there are a lot of questions that are still left to be answered. So, just to wrap things up, in general, in looking at what would constitute the best rehabilitation system to promote recovery, it's clear that the optimal system for recovery after trauma does not consist only of rehabilitation services. There are biopsychosocial factors that need to be addressed in addition to the treatments that we render in a traditional rehabilitation program. While it's clear that we need an approach of interdisciplinary teamwork, the optimal model of care and specific protocols have yet to be determined, but are currently under investigation. Thanks very much for your attention. I hope you have a great rest of the conference.